What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everybody? This is Dr. Zach Baker, and it's hard to believe, but we are halfway through February, a little bit over halfway through February right now. We are into, the sixth month of our residency program. With me today, I've got Dr. Bami Adu, our resident who is in our Germantown location. And the theme of the month for the residency in February is the spine. So we had Dr. Ashley Young come in earlier this month and do part of our classroom time with Christian and Bami, going over different evaluation techniques for spine-related injuries. This morning, we've actually already gone out to Oakdale High School, did a guest lecture in their sports medicine class, and now we're wrapping up the month with getting into our journal article review. And Bami, if you don't mind, do you mind touching on the article that you chose, how you came across this article, and why you really thought it was relevant?
Sure. So the article we're going to talk about today is Rehab Considerations for Spondies and a Youth Athlete. This is actually an article we talked about with Dr. Ashley in one of our residency classroom time. And I thought this article was cool because there's a lot of articles out there about the diagnosis of spondies, the healing time of it, and whether or not you should brace or not, and how much rest you take from activity. But there isn't that much articles out there about best clinical practice with spondies, of how to progress the patients, what to start them off with, and how to return them back to sport. As we go through this article, you're going to see that it gives a very good framework of how we can start getting these patients back into sport.
That's awesome. And I think, spondies are one of those conditions that you learn about in PT school, but until you actually see one and treat one in real life, I think some of the diagnostics are the ones that, and this may have just been personally, I wasn't the most comfortable with, and being able to differential diagnose between other low back injuries. But then the thing that I always seemed to be the least confident with was forecasting what their exercise progressions were going to look like, what we were focusing on in their rehab, and really what the expectations were for the individual in regards to what they should be able to do and what they should be able to tolerate. And Bami, can you allude a little bit to just kind of the bulk of the article? What did they cover? What were some of the main topics and themes?
Sure. So this article was a clinical commentary, so I was really just going through best clinical practice, getting in a bunch of articles together, and discovering what we should be following as PTs. So there's a couple of endpoints this article talked about. So one of it was the prevalence of spondies, and they found that 14 to 30% of adolescent athletes reporting low back pain does have a spondee. The mechanism of injury tends to be patients that are doing repeated extension of movements with rotation, most common in your sports like baseball, throwing events, cricket, diving, gymnastics, soccer, wrestling, weightlifting, any sport where you do a lot of extension and rotation. Clinical presentation for these patients, it tends to be atraumatic, insidious onset, focal low back pain, which worsens with activity, pain that worsens with lumbar extension without radiation to the legs. They also saw for imaging with these patients, they didn't really find perfect imaging. There's a lot of research out there whether CT is better than MRI. This article said typically CT is a gold standard, but then MRI is not too far off. They also found that when it comes to outcome measures for these patients, we like to use the ODI typically, but with these patients, there's something called the Micheli Functional Scale, and they found that this is a better outcome measure instead of the ODI because ODI is typically used for your ADLs, for your older population patients. Again, they talked about surgical versus non-surgical approach. As we all know, non-surgical is usually the initial treatment, and surgery really shouldn't be a line of defense until they've went through at least 6 months of physical therapy, and you won't start thinking about surgery if they're not getting better within those 6 months. This article also looked at cessation from activity, so they recommended that for at least 3 months that patients should not be doing much activity. And then the article had a lot of varying research depending on when to start PT with the diagnosis of spondies. So some were supported beginning PT, recommending starting early when the symptoms resolved, and others recommending after 3 months of rest. There's really no conclusive evidence which one was best, but you could take away that even if they're coming to PT right after having a spondee, we may not be working on the low back initially, but there's also other things that we can start to do, get these patients back into activity. Article also looked at whether or not we should go with bracing or not bracing, and some doctors like to brace, some don't, and there's no conclusive evidence kind of supporting bracing or not bracing. Lastly, looking at the prognosis of patients with spondies. So for patients with non-surgical treatment consisting of activity restriction, rest, and physical therapy with or without bracing, 92% of these individuals are able to return to sport with little to no pain within 6 months. An interesting thing about this is the bony healing time. So what they also found was that in a meta-analysis of 10 radiographic studies, only 28% of spondy lesions actually healed. So what we could take away from that is that spondy lesions may not necessarily look like it's healed on radiographic imaging, but patients are still reporting back to sport. So we shouldn't clear patients based on radiographic healing, rather clear them based on are they progressing with PT and kind of the stepwise approach. And this article does dive into 3 different phases of how to return them to sport.
There is a lot to unpack there in what you had just mentioned. And I'm going to recap just some of the big themes that resonated with me. The thing that I found interesting was you had mentioned 14 to 30% of these individuals with low back pain also had a presence of a spondy. So I think that was a number that was a little bit of a surprise to me just with regards to the prevalence and how common they can be. And it serves as a good reminder for your clinical exam on that first encounter with them to really make sure that you're deep diving into the subjective portion of the exam. Where do you feel symptoms? Because you had mentioned that they do follow a pretty specific pattern. They typically lack the radicular, the distal qualities that some of your other low back issues will have. And they tend to be very mechanically based, oftentimes with extension, rotation, or some combination of that. So I think if we're doing our due diligence during the subjective portion of the exam, that's going to allow us to start to figure out, does this present like nonspecific low back pain? Does it present as a disc or something radicular? Or could it be more bony or the presence of a spondy? You had also mentioned a little bit from an imaging standpoint that their MRI and CT can both be utilized for this. CT tends to be the gold standard, but it is common that in our field, we're often going to get the MRI prior to the CT. Sometimes that's insurance restrictions. Sometimes it's just the step-by-step algorithm that they go from an imaging decision-making standpoint. But keep in mind, if you're suspicious of a spondy and an MRI comes back negative and they're not progressing the way that you would like them to or within the time frame, further imaging may be necessary, which also leads to that next component where 6 months was kind of the time frame I kept hearing referenced in regards to what the time frame can be for a successful return to sport. And it did sound like conservative treatment can be highly successful. Was it 92%, I think you had said, actually are able to return to sports successfully within 6 months? And with the populations that we work with who sustain these injuries, I think that's a good and important time frame to keep in mind, that this oftentimes is not going to be a 4, 6, 8 week injury ordeal. There may be a lot more prolonged time that they're dealing with this. And how we are dealing with that is going to drastically vary, and it's going to change. And you hit on a lot of different things with regards to, do we brace or do we not brace? Sure. Do we do PT immediately or do we wait for PT? And I was kind of laughing to myself as you were talking about that, because I can think of probably 5 different spondies that I've had that have all been treated in a different way. And I've had some that say, hey, my physician, they want me to wear a brace. They just want me to rest. And they want me to rest for 6 weeks, then I can start PT. But when I start PT, they just want 6 weeks of mobility. At that point, I'll be 12 weeks removed from the injury. At that point, I can start doing more strength training. After that, I can start get back into more contact, impact, sport-specific stuff. And it's a very, very structured, detailed protocol that you're following that is more timeline-based as opposed to criteria-based. I've had others come in that they say, yeah, I saw my ortho. They said that there's a spondy. They told me that it may show up on the imaging for upwards of a year or even longer than that, but they want me to progress back to sport based on how I'm feeling. Sure. So they said, go to PT, listen to your body, listen to your PT, start with some of the easier stuff, stretch out, get symptoms under control, start getting back into a little bit more aggressive exercise. If it hurts, stay there or regress back. If it doesn't hurt, do a little bit more. So it's kind of funny. It's that classic answer of like, it depends on what you actually do. But you had alluded to, they talk about different phases with regards to the rehab continuum. Do you mind talking a little bit more in depth over how they categorized, I believe it was 3 different phases. What did they title those phases, and what is really the main intent or the goal that is being accomplished?
Sure. So yeah, there's 3 different phases. The first phase is isolated training. When we think about this phase, think about the very acute phase with any type of rehab, right? Patient education, modifying activities, and reducing pain. They actually paid a lot of attention to patient education and kind of minimizing that fear avoidance belief. And there's a lot of articles out there talking about how low back pain has a very direct correlation with your fear avoidance beliefs. And especially to these patients, right? These are adolescent patients. When they think of low back pain, they think of like something chronic, something that only like older adults get. So it's really important that we start to educate these patients that it's normal for them to get this, and there are certain things that they could be doing. And this article also talks about when they're in this phase, we could get them, and we should get them back into doing daily activities. Some of these patients might be very scared to do some of these activities, especially the ones that are in brace. They probably feel like they shouldn't be moving much. But this article kind of shows it's good to get them to doing some activities of daily living, and we should start getting them into that. Another objective is getting them to minimize pain. And when it comes to treatment for these patients, we want to start working on some of those local muscles. So, work on your multifidi, your TA, your quadratus lumborum, working on them, but in neutral spine position and a table supported position. So this is probably in this stage, these patients are probably going to be more so at the table and trying to get them into getting activation of those local muscle tissues. Also, during this time, right, we're going to start adding some mobility now. And, for these patients, let's say, for example, you have a baseball player and they're having a spondy and they're playing baseball, and now you don't want to do too much aggressive stretching for these patients. But now we can start to look at why do they have the spondy, right? So if it's a baseball player who's lacking like ER or thoracic rotation, maybe we start to kind of work on the shoulder a bit, right? So starting to look at different mobility deficits in these populations. And then the article goes on and talks about what are certain things we could look at and test and assess and different criteria to kind of advance to the next phase. Next, we have the integrated training phase, and that's the second phase. And that phase is really just progressing from the first phase. So you start off with more isolated training of the muscles. Now you take a more global approach. You start to add some more resistance training. You start to, instead of going from the table, now you get them to different positions. Maybe now you start to add some pal-off press. You go from single plane, now you're adding some multi-plane. Again, this article also talks about how we can progress these patients and how to test and assess and what things we're looking at in order to progress them to the final stage, which is your return to sport training. And your return to sport training looks very similar to any other return to sport training with any other injury, getting them back into different positions that they need for their sport and getting them back into running during this phase.
And with those 3 phases, it sounds just like how you would address really any other injury. You have early through late phase. Your early phases, you're focused more on just general health, wellness, ADL-based activity. And during that phase, from a rehab standpoint with regards to exercise selection and what you're doing from an intervention standpoint, you're probably a little bit more tunnel vision on how do we get some of these localized tissues and these local muscles of the low back to start doing their job again. You had mentioned multifidi, you had mentioned QL, you had mentioned TA, some of those different muscles that do play a large role in core stability or just the sequencing that's involved and required to do a lot of movements throughout our core in a coordinated and stable and efficient fashion. I think one thing that is important to remember with that, we should not have to actively think about contracting our multifidi, contracting our TA or QL. A lot of that stuff should just happen subconsciously. I don't think about making my diaphragm contract in order to breathe. It just happens. So how we do that oftentimes, you had alluded to, is the positions we put these individuals in. So I think early phase rehab, another way to think about that, instead of trying to find exercises that target muscles, find positions that you want that individual to be competent in, or positions that you're trying to allow them to tolerate better. And we're figuring out what's their total motion they can work through, what can they demonstrate tolerance and competence within. Then you can reach into your bag of tricks and into your bag of exercises to figure out what's going to elicit that outcome. And maybe for them to get their QL or TA or multifidi or rectus or obliques, whatever, deeper or more superficial layers of muscles you're targeting, are we going to get this more through an isotonic or an isometric muscle contraction? Are we going to do something that's focused more on sagittal plane competency, or are we looking more frontal or transverse? So we can get into potentially our anti-extension activities, our anti-rotation activities, something that may preserve the integrity of the position that they are in so that we're not putting them in provocative positions, but we're still getting the appropriate muscle activation and muscle control that we're going after. When we get out of that phase and we're going into more of those middle phases, and this is where they talked about not the isolated, but the integrative or the integration phase. How can we get those muscles to not only work in isolation, and how can we not only get them to work when we are consciously thinking about what they're doing or the position that we're in, but how do we make that second nature? How do we maintain the appropriate core, lumbopelvic, trunk relationship or stability? How do we dissociate hips, pelvis, trunk on one another as we're doing a more functional foundational movement pattern? When we're squatting, when we're hinging, when we're doing an upper extremity activity. How does that relate to multiplanar, multi-joint tasks? And then once we can accomplish that, then it's how do we make those tasks more challenging? Can we increase the resistance associated with it? Can we increase the intensity, the volume? Maybe we're modifying tempo or adding degrees of impact with it. And once we can show that we can do all of that well, then we start to think about how does this start to look more and more like the sport that we're getting back into? How can I make this rotational core activity start to look like swinging a baseball bat, or start to look like some of the things I need to do on a gymnastics beam or a bar? So I liked the article that you had selected, and that I thought Ashley did a phenomenal job when she was in here in the classroom talking about how you would have that article translate into a clinical evaluation, and then what you are doing from an exercise selection standpoint. It's always refreshing when you hear these articles that are peer-reviewed, and they are echoing a lot of your internal thoughts that you're having and things that you're already intuitively programming in. But it does give you just some more, just a little bit more backing when you're communicating it confidently to a patient. This is what we want to do. This is what our expectations are. These are the time frames we expect them to be within. And this is how we are coming to that conclusion based off the evidence and the literature that we have. So, Bami, as always, I appreciate you doing the dirty work, finding the articles, digesting them, figuring out what's relevant from it, and then sharing it with the rest of us. And I look forward to next month when we have you on here and seeing what you can come up with.
Thanks, Zach.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.